Welcome, and thank you for joining Axxess and our industry experts to hear their strategic perspectives on CMS's calendar year 2026 Home Health Final Rule. Today's discussion will cover the impact of the final rule on home health providers and patients, and provide actionable strategies that your home health agency can implement today to minimize the financial impact on your business. We will also hear about the importance of leveraging technology, provider compliance, star ratings, and accurate cost reporting to safeguard your business operations, not just in 2026, but into the next decade. Hello, I am Raianne Melton, Senior Director of Clinical Services at Axxess. Thank you for joining us for this live web conversation. Before we get started, we've got a few quick notes for you. Today's webinar is being recorded, and we'll share a link with you by email in the next few business days. We won't be taking questions during the webinar, but feel free to post them in the question box, and our panelists will reply to you personally by email. In the question box, you will find a link to the Axxess Industry Survey. Please take a few minutes to complete this survey, which is focused on understanding how your organization is using AI. It'll be a really big help to us. At the end of the webinar, we will share a QR code for information about how you can register for the Axxess Growth, Innovation, and Leadership Experience, Agile, the premier industry conference on technology and AI in the care at home space, taking place in Dallas, May 4th through 6th, 2026. And now it's my pleasure to welcome our panelists. First, I'd like to welcome Bob Markette. Bob is a health law attorney at the Indianapolis-based firm of Hall, Render, Killian, Heath, and Lyman, with more than 20 years experience handling operational, compliance, legal, and regulatory issues facing home care providers. And Arlene Maxim. Arlene is Senior Vice President of Clinical Services at Axxess, a national home health and hospice expert and author of the book, The Survey Trainer, or as I like to refer to her, the goddess of information. Welcome to you both.
Thank you, Raianne.
Yeah, thanks.
So, Bob, let's begin with you. CMS published the calendar year 2026 Home Health Payment System rate update and final rule on November 28th. The explanation of the final rule is quite complex. Thankfully, the overall payment cuts are far smaller than recommended in the proposed rule, with the overall payment reduction of 1.3%. However, there are permanent and adjustments to the 30-day payment rates. Bob, first tell us a bit about your work at Hall Render and your experience in the home health space. Then let's dig into the CMS comments on the decisions around PDGM and payment reductions. What are your thoughts on CMS's discussion points?
Sure. Well, I don't have much more to say about me or my experience. You kind of covered it. I've been working with the home care industry, home health, hospice, private duty for longer than I care to admit, because it reminds me how old I am. And so this is the 24th time I've gone through the CMS final rule process. And surprisingly, they managed to make it more painful each year, which kudos to them for always raising the bar. And this year was no different. It's interesting that, as you noted, and I think as a lot of us expected, they backed away from the cliff. They came out in the summer, proposed with the PDGM budget neutrality cuts that they were going to make a 9.1% cut in home health reimbursement, which is crazy to say out loud in terms of given what our expenses and costs have done over the last 10 years, they think we can afford it almost 10% cut. But as they've done each of the last few years, as they've implemented this PDGM budget neutrality, they make a huge opening number and then they come back. And in this case, they went from the proposed 9.162% to proposing a little over 1% permanent cut and a little over 3% temporary cut. So they've given us some breathing room. What's interesting, because I think a lot of us anticipated they weren't really going to impose a 9% cut, just based on what they've done the last several years. What's more interesting, the comments. Both the industry has made a lot of comments because this was considered to be a life or death matter. But CMS's responses to many of them, some are not surprising. There are many comments about the methodology. We've objected to the methodology. The Alliance, as formerly known as NOC, actually litigated the methodology and lost. So we've long been concerned that the methodology doesn't really adequately capture or address these so-called behavior changes. We've also been concerned, in fact, whenever comments were raised, that they seem to be basing their decision-making and rate cut decisions, or rate setting, I should say, on behaviors they didn't tell us were going to be considered when the PGM rule came out 5 years ago. And they acknowledge that. And they basically say, yeah, our methodology captures all the behavioral changes, which raises some serious questions about things they've said in the past, their rulemaking in the past. If your methodology captures everything, then my suspicion is it captures nothing. But they dismiss a lot of our normal complaints. There were complaints about the impact, what it would mean to agencies. We raised a lot of concerns about the fact that this would cause access issues, and there was data cited by the industry, which, as they've done each of the last 3 years, CMS points to their own data. It says there's plenty of home health agencies. There's no problem. There's no risk of access here. There's actually discussion of comments about subsidy. They call it subsidy. I call it operational reality. The operational reality is Medicare. The tiny profit we make off of Medicare allows a lot of agencies to do Medicaid and other services. And people noted rightly that that would be a problem. It would lead to a reduction in other services. And Medicare dismissed that as we're not here to subsidize the other payers. But the most interesting discussion, I think, has to do with, in the discussion of the methodology that they use here, there was an admission by CMS, at least I take it as an admission, that once you get past 2023, they agreed with the commenters that you can no longer adequately identify behavioral changes due to PDGM versus behavioral changes due to other policy decisions. CMS acknowledges they've made many other policy decisions since 2020. And they note there's a lot of data. They say this, I'm not sure I agree with them, but they say there's a lot of data showing significant changes in agency operations and behavior in the first couple of years of PDGM, which they attribute to the payment model change. But then they note that changes after that, they're no longer as confident that they can directly tie those back to the PDGM payment changes as opposed to other things. And that's part of their rationale for walking back the permanent cut down to 1%, is that this inability to connect the dots, which raises a question for next year. Now that they've admitted in the Federal Register, in comments, that they can no longer identify behavioral changes due to the payment change, how does that impact what they do next year? Because it seems to me, having made that point in the comments this year, it becomes even harder to justify any kind of permanent change or permanent cut based upon behavioral changes next year as the data gets even a lot more tenuous with the passage of time. The flip side of that is the temporary cut they need to impose to recoup what they consider to be the overpayment that has been accumulating since the beginning. And in their comments, they note by their projections, and again, I think we all take that with a grain of salt, the new payment system has resulted in an overpayment as to what would have been paid under under the old pre-PDGM system, PBS, of $4.7 billion. And they said that the 3.05% temporary cut they're going to impose this year allows them to recover $471 million of that $4.7 billion. And as they noted last year, they note again it would require a 34% temporary cut to recoup that $4 billion. And so there's a question there as to what does that mean for next year? Do they potentially let the temporary cut, the permanent cut go and replace it with a much larger temporary cut? Because they've suggested several years now at some point they've got to recover all of that. So I think while we are happy about the fact they step back from the 9% cut to I would say I still think a full or 4% cut in current dollars unreasonable. What does that mean for next year in terms of the temporary adjustment to deal with this alleged overpayment And do we need to be able to look out next year for perhaps they don't even bother with a permanent cut and they simply look at a large temporary cut, recover that $4.7 billion, or might they decide that, because they've conceded in other commentaries that the 30% cut would be impossible, or wipe out the industry. And maybe then they would consider letting this all go, and maybe would pass on. So you can see where we go to next year, given the comments here and CMS' response. I think CMS has put themselves in a position where imposing a permanent cut next year gets more difficult if you've already conceded. You don't really know what's causing behavioral changes this year or last year because we're so far past PDGM. So I found that to be the most interesting part of it in terms of their comments. I thought the industry did a really good job in terms of making comments, raising the issues, even though I think we all figured they would be dismissed. But continuing to record as to the impact this is having, given that our costs keep going up, labor costs keep going up, and their model doesn't understand that. And want to comment, and I'll stop. But some commenters noted that they called it a feedback loop. I call it a depth spiral, where they cut our rates. We modify our behavior to reduce our costs for us to survive, and they use that as evidence to cut our rates. And commenters noted this is a feedback loop that just is going to spiral down into account operators. At some point, you can't keep finding savings. And I thought it was good of the industry to call that out. But I do think that's the trajectory you're on. Again, CMS didn't seem to care. They always discount our data, and they at MedPAC seem to think we are making a lot more money than we are. But I did like that the industry called out their feedback loop, because it's been a concern I've had in our means course as well for many years, that every time they cut our rates and we find a way to be more efficient, we get penalized for being efficient, which is really counterintuitive in terms of a reward system.
Stop. Boy, that is quite perplexing and scary for sure. So Arlene, let's move to you. Your work with home health agencies across the country for the past 30 years has focused on clinical compliance, improving agency star rates, and leveraging technology to drive operational efficiency and maximize revenue. In last week's Maxim memo, you broke down the components of this rule. What operational changes will agencies need to make in response to the recalibrated PDGM case mix weights, updated LUPA thresholds, and functional impairment levels?
Well, thanks, Raianne, for that question. I think that part of what Bob was talking about and not seeing changes recently as a result of PDGM, in our industry, I've seen over the years, and I know Bob has, that it's really hard for our industry to make changes at all. I mean, our industry does not like change. And if we're forced to make a change, it's hard to undo that change. And one of the things I found, and I find very interesting, is that home health agencies, since PDGM, since COVID in particular, COVID got right in the middle of the PDGM issue, and so we had to deal with that as well. But we had a reduction in both home health aid services and occupational therapy services. I think I have a hunch if we would look back, we would see a significant change in that. I think that in the future, we're going to have to see, and when I was listening to Dr. Oz talk about the new Axxess, the Medicare Axxess, interesting that they chose that name for the Medicare program for this change for technology. But I did hear them talk about having clinicians work to the top of their licenses. I believe that the industry itself needs to go back and take a hard look at home health aid services and how they can utilize home health aid services at the top of their license. Maybe do some additional training with the home health aides so that we're not putting as many what we call now skilled services in the plan. That there are many, many things that the home health aides can do that we just don't even give them the opportunity to do, but that certainly would save costs. I also see that cited in surveys. I see the citations where the agencies are not using, particularly home health aides, not as much occupational therapy, but in particular home health aides, just aren't using the way they used to use them. And so I do think that foundationally, we have to start looking at how we're going to design our programs. We have to make sure we understand what the LUPA, there weren't a lot of LUPA changes, but there are some. And so they have to understand what those are and be able to design. And I think that we have to start thinking about at intake, number one, whether or not we're going to take the patient, because some of the patients are going to be much too costly. I know some agencies that are taking quite a few Medicare Advantage program patients who are actually getting paid less than it's costing them to provide services for the patient. And that's not a good place to be. And so we really need to analyze that and find out where we are with that. And in addition, we have to make sure that we're watching those missed visits. Missed visits almost always equal rehospitalizations. So that's going to be something we're going to have to take a really hard look at, because if your staff members aren't making the visits that they need to do to design their program to make sure their goals are met, then they need to take another look at the types of insurances they're taking and whether or not they can handle them with the number of visits they're being given them. The other thing with the HH caps, they reduce that by a few questions. I do think that the clinicians need to understand what HH caps is. That is a report card on their care, and I don't think they understand that. They don't understand the questions. Many of them have never even seen the questions, and it gets confusing because we're told that we can't coach the patient in the actual questions themselves, which is true, but that does not mean we should not have a really good understanding what those questions are and what we need to do to achieve them. It's like going to school and taking a class and not having any idea what the test questions are going to be on a completely different test. So I think those things we really need to be taking a look at. There's a reduction in some of the OASIS questions, so we need to know what those are and need to be able to make sure we're training the staff. The GG codes and the M1800s, I think there's no room for a lack of education there. That needs to be taught over and over and over again. It's not a one and done type of thing. I think it's a repetitive type of education that needs to be done on an ongoing basis to remind people, because you become complacent when you go out there and you check those boxes over and over again on hundreds of patients. You become complacent in the way you actually function. And so that re-education is going to have to happen, but and keeping those rehospitalizations down.
Great. Arlene, also as a follow-up, we know that emphasis on compliance and operational efficiencies is rooted in driving quality care. What are the key changes to the home health quality reporting program, and how will the removal of certain OASIS items and COVID-19 vaccine measures affect quality reporting?
I'm not sure that the COVID question had any impact whatsoever. Some of the socioeconomic questions about feeding and eating and that type of thing, they were all pretty standard, so they didn't really see that they had an effect on the way we had the way the outcomes were returned. So I don't think it's going to be that much exact. Again, as I mentioned earlier, I think having a really good handle on and continuing education on functional items is going to be the big thing. And
thank you, Arlene. So we'll move to Bob. From a value-based care perspective, how will the nationwide expansion of the home health value-based purchasing model, incorporating new functional improvement measures and revised weighting of quality domain, affect agency performance metrics and financial incentives?
I think the big thing with the rule is, and a number of callers raised this, so we're all aware, right? They did the expansion. July is kind of coming up here is D-Day, where we're all going to find out who's getting, to use a holiday analogy, since it's December, who's getting coal and who's getting a present. But in the meantime, the problem we have, and the commenters raise this, is they keep changing the rules, if you will. They add or remove measures. They say we're doing this to provide innovation or incentivize innovation. But commenters raised several really good points, including that, look, you gave us a target date, and then we invested resources and effort to hit that target, because if we don't hit the target, and it's not that we hit the target as much as we get closer to the target than our competitors, because this is essentially home health Hunger Games, as I've said before. There will be winners and losers, and it's not that you're competing against an independent objective standard. It's look to the left, look to the right. Somebody's going to lose. And so we have now, what are we in, year 2, year 3? We've been working on this. We knew it was coming. We've taken steps because we were told these are the measures. These are the things that we're going to use to determine your TPS score, which will determine whether you win or lose and where you fit in your cohort. And then they keep changing the rules. It's like, I think back years ago when I watched more racing with NASCAR. The season would start, they'd start racing, and one team's cars wouldn't be as fast, and so we changed the rules. We give them, they give them a more rear wing or whatever they do to try to make it more competitive. Well, the problem with that is if you change the rules in the middle of the game, it's hard for me to know how do I win the game? How do I, and especially when we're talking about significant cuts, if I'm in the bottom of my cohort. So the commenters have, I think, a very good point in regards to the changing of the rules. And CMS just kind of shrugs their shoulder, well, we're allowed to, and we're going to, and good luck. And it's really funny. We talked this yesterday. We haven't even seen the results yet for the first go around. Like, those are still coming. And I think this is the second time they've changed the rules. And then when they're adding these measures, the one that I think is most concerning is this PAC measure they're adding. They're now saying, look, you're going to be graded using the and I've got it written down because it was too complicated to remember. MB whatever. Sorry, I'm not the data guy. That's Arlene. I'm the complaint to the government that you're doing it wrong guy. But this PAC measure looks at not, and the color's point is not, it doesn't look at quality, it doesn't look at outcomes, it looks at Medicare expenditures. So it's home health value-based purchasing and Medicare expenditures. And it's not just our expenditures, because we get a fixed amount based upon the herd, full stop. We're going to be graded based upon all the Medicare spend in this post-acute time period. And that means we're once again at the mercy of other providers. Face-to-face, we're at the mercy of the docs. Certification, at the mercy of the docs. Now we're at the mercy of these other post-acute providers and how much they spend, how good or how bad they are, which means one of the elements in my score is not under my control. And CS talks in the comments, well, you'll, through care coordination and other things, you'll be able to work with the providers to control this. And I want to say to CMS, you clearly have never operated in the real world, because we have zero control over what these providers do. In the closest analogy I can get to this would be some of the bundled payment initiatives that we got out of healthcare reform to the Medicare Innovation Group. But those were bundled payments where we all got together. The hospital was in charge and they had a plan. This is what will happen. This is what you will get. And we didn't control it. We did what the protocol called for us to do. So that's where you saw significant reductions in physical therapy for post-op knee replacement patients as part of the hospital's paradigm. Well, this is flipping that around. The tail of essence wagging the dog, where we are now supposed to, through coordinating with other providers, reduce their Medicare spend. And so I don't see any project where we're going to control that, which means your TPS score, now maybe it harms everyone equally. Maybe this is a case of we all lose together and so it doesn't matter. But I suspect what's going to happen is, perhaps a random fashion almost, some providers will be benefited because they happen to be at a locale where there are good qualified providers who are consciously working to reduce the Medicare spend. Others are in areas where the providers don't care and the post-acute spend is high, and they'll get penalized for something over which they have no control, which raises a question to CMS, and that is, if you're attempting to create a program to drive financial incentives for us to improve our care and our outcomes, why would you include a metric that we cannot control? You might say it's punitive in some sense. I know part of this may be, Medicare had the goal, because all this PAC stuff comes out of their search for the holy grail of the single payment that would cover all post-acute, which is akin to saying, we're going to set one price that's going to cover traveling by train, traveling by plane, traveling by automobile. It's not possible. And so maybe they're attempting to backdoor this here, but my fear is that all this is going to do is penalize providers. And frankly, and I'm not necessarily one that thinks home health database purchase is a good idea to begin with. And perhaps that's just my general skepticism. But to the extent it was a good idea to create a financial incentive to improve performance, and they seem to think there's data from the pilot project that it did, why would you muddy the waters by adding something I can't control? It's like, I think the provider's concerns that raise accounts are all valid. I don't see how this is going to work. And my fear is that it's going to impact database purchasing in a way where providers may find their scores impacted for something they can't control, which if I can't control how database purchasing impacts me, maybe I'll shrug my shoulders and say, you know what, you guys keep changing the targets and you add measures I can't control. What incentive do I really have to try here? Like I can't win because the game is rigged. So it'll be interesting. I'm concerned about that, because the concept of value-based purchasing seemed like a reasonable concept, but the way they have executed it, and they keep changing the target, they keep changing the metrics, and now they're adding metrics we can't control. I think it's a bad idea. I think it's going to have unintended consequences. And I don't know practically, Arlene and I, as we try to provide some advice to providers on what to do, I don't have any practical advice for how do I control other provider spend. So it's frustrating. I don't know what to tell you. Maybe Arlene, she's always good with ideas and how to control folks. Maybe she's got an idea that doesn't involve blackmail, but I don't know.
Doesn't involve blackmail. With that note, we'll go to another question. This question is for both of you. Given the ongoing payment cuts and increased regulatory requirements, what strategies should agencies adopt to maintain financial stability and patient access to care in 2026 and beyond? And Arlene, let's start with you. What are some strategies for our agencies?
Well, I think that one of the things that needs to be done is to make sure that the coding and the clinicians are updated on training and coding. I'm seeing so many variations in coding, and everyone's getting caught up on this AI situation, AI and coding, and I'm not so sure that AI is ready for that degree of specificity yet. So I think everyone has to be really careful. I think they have to do a lot of research on how their coding's getting done, if they're doing it internally, making sure that their staff are being trained properly. With PDGM, I would do, if I were managing a company, I would be comparing my PDGM information with what I expected to be for this year, then for 2026, and how I'm going to be able to reach a level that I'm going to be able to even break even on something like that. Again, I can't express enough how important it is on training and retraining on the functional assessment items, your GG codes, your 1800 codes. Those 1800 codes are directly impacting. And like Bob said, some of that stuff the rehospitalizations and some of those things we don't necessarily have any control of whatsoever. But to the degree that we do, I think that we have to, you see it on the news all the time that the mentation of folks, that has a high degree of whether or not we're going to be successful in our plan to get the patient ready to be discharged from care. And I see very little improvement in cognition from the time a patient starts care to discharge on most charts. So I think that I know that there are programs out there that deal with that. I think we have to agencies need to start taking a hard look at some of those programs that are available. I know Axxess has some partners that deal with that very well and can actually help with cognition and help improve our scores. And then when Bob did mention the face-to-face, that's one of the gifts, I guess, they provided to us in this final rule. Making sure that you've got a better, or you have a good position with your NPs and your PAs. I mean, I think that there was a time where we had to, argue a little bit with them because some of them were confused as to what their abilities to do. They had different capabilities in nursing homes and hospitals than they did in home health. So we didn't always see eye to eye on that. So I think that getting those relationships back into a normal phase and be able to work with those folks so that knowing that they can sign those face-to-face documents now is a really good position to be in.
I agree. Bob, what are your thoughts?
Oh, I guess the good news is we don't have to find 9% of saving our budget. We don't have to find, what's the final number capped, like 1.3. So, now if you can find more than that, great, because you'll probably need it next year. So obviously one is, ways to be more efficient, although understanding, as noted in the comments, we're feeding into that death spiral where we find ways to survive and it makes us look bad and we get penalized for it. I think Arlene's point about technology is correct. I think at this point, I think the primary driver of efficiency is going to be technology. I think AI is a component of that, but I think Arlene's warning is a correct one that AI is still, I think, and I may be considered a Luddite for this, a bit of a beta technology. They're still working up the kinks, and there are, I think, promises being made that are being taken at face value. And I think a lot of, and this isn't just in home health, I think there's a lot of industries where we're so quick to jump on the next technology bandwagon, we're not asking questions. And with AI and some of the things that the tech companies are trying to do, and the AI folks are trying to do, the providers are forgetting that they still have a responsibility. Mm-hmm. And as good as the AI product might be, and as we're doing these things to be more efficient, which I think we have to be, we can't forget that we are still responsible. We still oversee it. We need to verify it. Look, whether it's software or hardware or whatever you're doing as a salesperson, they may make promises that the guys that are actually coding the solution, like, well, we never said we could do that. So you want to be sure that you have the compliance pieces in place, because if you have whatever the technology solution, whether it's AI or an EMR, whatever, and it makes a mistake, Medicare will hold you responsible, not the vendor. So we need to be sure we have the compliance tools in place as we're advancing that technology. I think similarly with technology, remote patient monitoring. Arlene talked about the pandemic and some of the things it drove, some of the change it drove in home care. One thing was we got more comfortable with using remote patient monitoring. And I've got a lot of clients that use remote patient monitoring in the home, tied into the EMR, to get data on patients when they're not there. I've taught the clients to say, look, we can actually get the same or better outcomes while reducing visits, because if the patient is bought in and using the technology, because of the data we get between visits. And so there's another way to get efficiency. Face-to-face, I think they gave us some flexibility there. But be careful. If you read the comments, CNS is going to say, hey, we're going to disconnect. It's not going to be the physician that saw the patient. It's any physician. But in the comments, they very clearly say the physician has to in some way be connected to the patient in relation to. So I think, though, you're going to see some audit issues over who's this physician, how does he know the patient, why is the physician doing face-to-face? So be prepared to defend that. And the upside is, in those same comments, CMS once again stated that there's no requiring the face-to-face documentation include a diagnosis code, because that's been an ongoing audit issue. So once again, we can point to CMS's comments to the auditors and go, look, they don't say we have to have an audit code here or a diagnosis code. So you can't ding us because our diagnosis code doesn't line up with the physician. It can still be related. So that's want to think about that because those are the recurrent audit issues. And then the other one, I'm frankly surprised that Arlene didn't mention this because she's been banging the drum on this for years. And that is cost reports. We have got to get our act together on cost reports. The commenters, we acknowledge in our comments that, look, the cost report data may not be that great. We have for years shot ourselves in the foot because we're not doing the cost reports properly. So we need to, because they're using our bad data against us. And, back before I got into law, I was in computer science. And one of my favorite phrases is garbage in, garbage out. If our cost report data is bad and they're using that against us, we have no one to blame but ourselves. And so I feel like every year we do this webinar, and that's why I said I'm surprised Arlene didn't say it. Arlene's like, you got to fix your cost reports. We've got to get that data correct, because while I still blame them, but at the same time, I can't blame them if they're using our data and our data is bad. So understand, because our cost reports don't directly tie to reimbursement like they did in the bad old days, we have become somewhat more cavalier about them. But they do still tie to reimbursement. Medicare uses that data to justify these rate cuts, to justify that, well, you're way overpaid because we're not paying. We're not making a 25% profit. That's not how home care works. But our cost reports apparently make us look a lot wealthier than we are. So that's the other thing I'd say. We really need to fix that so we can get correct data to CMS, because maybe that will help them to see we're not all living in mansions and driving Maseratis.
What's really scary is when we use the old information using AI to put it in a cost report. That's gonna drag us into infinity with bad cost reports. If that's what some of the accountants start doing, they just use that old data. And MedPAC has already said that they're going to look for another 7% cut next year based on what they have.
Well, I would argue that AI and cost reports, given that they use old data to train these models, that at least for home health, any home care cost report AI is going to be something to avoid, because it's fed all this bad data we've been complaining about for years. So, and yes, that sound you hear in the background, that sounds like the Jaws theme song. That's MedPAC already clamoring for more next year.
Geez. Okay. Here's another question for both of you. As a National Alliance Breastfeed Ambassador, I had the privilege of participating in the fly-in to Washington, D.C. in September of this year, where I had the opportunity to speak to legislators about the potential negative impact of the proposed rule and other care at home issues. Let's talk about the importance of advocacy and joining our national and state organizations. Arlene?
Well, I've always, I would encourage you to talk to them about cost reports. And let them know that they're not getting good cost report. I've always been an advocate of and joining organizations, and it's been a struggle. I mean, it's one of the things that, if somebody's looking at their balance sheet, if that's a number they can eliminate, that's probably what they're going to do. But we need to have advocates for us, and we need to have someone speaking for us. And the only way we can do that is through organizations like the Alliance and like your state organizations and other organizations that might be coming along that are going to have your voice heard. But thank you, Raianne, for doing that. I know that takes a lot of time and effort and courage to go beyond. I've done some of that myself, and it's not pleasant sometimes. It's not, you're not always greeted with open arms, for sure.
That is correct. But Bob, yesterday when we were talking about this, you talked about the power of individual agencies calling their legislators. Can you just share your perspective on how powerful that is from a local level?
Yeah. So, to jump off where Arlene was, I think joining the association is important, because then you know what's going on. And a lot of folks to Arlene's point with their budget, want to avoid that kind of ride on the coattails. The problem is eventually there won't be coattails to ride on if we're not involved. And we need to be active. And that's to what you just said. We don't have, even our national, we don't have the budget at the state level, the federal level, to compete with the hospitals and the physicians, the nursing homes. But there are a lot of us. Last I checked, there were more than 10,000 Medicare certified mental health agencies. There's more than that, in private duty, et cetera. And each agency has employees and patients. And so it's like the old, grasshopper and the ant. Maybe, individually we're small, but there's so many of us. And what I've seen, especially at the state level as well, is when there's an issue, it's not just the association going, but it's the members, it's their employees, it's in some cases patients, and they're calling and not just calling and reading bullet points. Like, though I've been involved in a couple of state level efforts here in Indiana, and we would put together talking points, but our big thing was we don't want to just call and read the same script because it's like robocon. They know what's happening. But I forget what the number was, but I had a state legislative aide say once that if they get more than 4 or 5 calls on the matter from their constituents, that's a concern. Like that tells them that there's something in their district to be worried about. And never forget, the primary job of a politician is to get reelected. And so when they get lots of calls, that draws attention. So maybe we can't get their attention through campaign donations and PAC contributions, but if they're getting lots of calls and it's a grassroots effort, and I think and I've told clients this in some matters we've been advocating for, get the patients to call. They need to understand it's not just when you call, you're the business owner, and maybe we get a bad rap. When your employees call, they're constituents who might lose their job because of policy change. When your clients call, they're beneficiaries of entitlements under these various benefits programs who may lose their health care because of policy change. That gets people's attention. And it doesn't always work, but I've seen cases where a concerted, consistent effort that got lots of people engaged, lots of phone calls, letters. Heck, at the state level, you can even show up and often go to the local office of your state rep or state senator or go to the state capitol, and you can really get their attention. And I know at the state level, we have averted some catastrophes because of that grassroots effort. We don't rely upon fundraisers as much as we rely upon the number of people that we can get to make those calls. And so I think it's very important to be part of these associations, to be involved, to be aware of what the advocacy efforts are, and to be submitting comments to federal right rules and writing and calling your state and federal elected officials. Because here's the thing. So this year, we again dodged a bullet. Now some may say, look, it was never going to be that bad. CMS is playing a game. Maybe, but if no one has said a word, maybe we'd be looking at a 9% cut. And MedPAC's already talking about 7%. They talked through what the need for a temporary adjustment next year. We cover $4.7 billion. We need to be proactive. We need to be already thinking about and making noise about, look, a 34% cut would destroy the industry. And it will destroy, and the fun fact is it'll destroy Medicare, because if you don't have us to support these patients that come out of the hospital, they're all getting in the hospital, they're all getting in nursing homes, and you're going to spend a whole lot more money. Like they need to appreciate us. And to do that, they need to hear from us. And so I think it's very important to be involved and to be active. And when you get those emails, and I know you want to you're busy and you want to throw them in the trash. But when the Alliance or your state association or whatever, or sometimes you're a nurse, you're a therapist, or a member of a professional association as well. They have home health divisions, and they might send an email. Read it and make the call, send an email, make that effort, because that's how we protect ourselves, by making that kind of noise. Because that's when they notice our industry, is when we're calling and advocating and seeing them, because we have numbers.
That's beautiful. Go ahead, Arlene.
I'm sorry. Take them out to do a home visit. When they're home on vacation, call them up, ask them to come to your office, take them to do a home visit, and actually have them watch what we do and what we're dealing with some of the patients. And I happen to know that there was an agency in Oklahoma in the late fall, who actually took one of their representatives out, and they made a policy change as a result of that visit. So that connection, as Bob was saying, is powerful, and we just don't understand what power we have in doing that.
I totally agree. I think that's the one thing I learned from, the times I've been in Washington, D.C., talking to my legislators. But I will tell you that on this trip I had I'm from the state of Arizona, and there were only 2 other representatives from Arizona, and they're from a small rural town called Cottonwood, Arizona. And they're both medical social workers at a hospice, and there wasn't any funds to send them to do this. So they did a GoFundMe. And the primary contributors to the GoFundMe campaign were their caregivers of their patients. And when we went in and shared that story with our legislators, we're here because the whole community donated funds because they're so concerned. It was a completely different conversation than I've had before. So, please, get involved and help us out here. So we're getting close to the end of our webinar here. And, I always love talking to both of you. I learned so much. We have a couple of minutes. This final rule, everything's going to be put into place on January 1st. What is one thing each listener can do today to prepare for January 1st? Arlene?
Teach. I don't know what else is going to help them, and make sure you get good cost reports out there. But but the teaching is in getting your value-based purchasing scores up and getting your star ratings up. That's so important to your livelihood, and that's the best example I can give for folks to be successful in this journey that we're all on.
Wonderful. And you, Bob?
I think I said it once. The cut wasn't as bad, so we're probably ready for that. It probably doesn't hurt to start already thinking about, okay, where else can I find savings for next year? Because we know it's coming, and thinking about, what efforts can we start making now to get out ahead of this and advocacy wise and make people understand so that we're already engaged when the proposed rule comes out next summer. And then I think on the value-based purchasing front, really consider these new measures, especially the PAC one. How does that impact me? Are there things I can do? Are there conversations I can have in order to and we're all even grayed out right now based on where I'm at, what's around me, to try to begin figuring out what does this metric that I can't control mean for my TPS score, and what conversations might I have with the other providers that feed into this metric that might help me in terms of where I'm doing my cohort.
Beautiful. Well, thanks to both of you. Thanks for joining the webinar. Thanks for all your wisdom. And thanks to each and every one of you who joined us today and who completed our survey for us. We're now going to show you a QR code so that you can learn more information about Agile. Please look for an email in the next few days with a link to today's recording and Axxess's landing page with tools and resources to ensure your success and understanding CMS's final rule. Have a wonderful day and happy holidays as we wrap up this year, everyone.
Thank you for joining Axxess On Demand. Visit Axxess.com for more on-demand videos, industry resources, blogs, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.